Please welcome Dr. Paul Harch, who will speak to us today about hyperbaric oxygen therapy and COVID-19, acute infection, long haulers syndrome, and vaccine injury. Dr. Harch is an internationally renowned HBOT expert. He has used hyperbaric oxygen therapy to treat more than 100 different conditions, including stroke, dementia, autism, and traumatic brain injury. He has the largest experience in the world in treating neurological conditions and injuries with HBOT. People travel from all over the world to be treated by Dr. Harch. Dr. Harch was the former director of the Louisiana State University Medical Center Hyperbaric Medicine Department. Currently, he is a clinical professor of medicine at LSU School of Medicine in New Orleans. He graduated from the Johns Hopkins University School of Medicine and did his postgraduate training in surgery at the University of Colorado, Denver, and radiology at LSU's Charity Hospital in New Orleans. He has written a book, The Oxygen Revolution, which is the definitive guide to hyperbaric oxygen therapy. Please go to his website, hbot.com, to read more about Dr. Harch's fascinating and illustrious career. Everything presented today is for informational and educational purposes only. Read the research, talk with your doctor, and make informed decisions about your health care. Please welcome Dr. Harch.
Janice, thank you very much. I just have to take one little time out quickly here. It says that for me to record this, I have to have permission from you. So if you guys can give me permission, I'll record it on this end. You can record it on yours as well. I know it's already being recorded, but.
You have our permission.
Good. Well, anyways, thank you for the opportunity. And, you had originally asked me to do this. I came up with a blank on your main topic, which is the last one here, hyperbaric oxygen treatment of vaccine injury. But when I sat down and really started going through all of this after I'd agreed to do this, I in fact have a case of this, and I'm going to present that at the end. But this talk, since I don't know the audience and how knowledgeable they are, but this really applies to our hyperbaric medicine. This therapy has not been understood for 360 years. So we're going to start from the beginning, and I'm going to go through this, and we're going to concentrate on some principles that I want to apply to our end question here of treating, well, acute COVID, long hauler syndrome, and vaccine injury. I'm not doing this on behalf of LSU. I'm doing this as a private person. So just to, yes, I have an academic appointment, all that, but I also have a private practice and company that I do consulting, treatment, et cetera. And so I'm not doing this under the university, just to be clear. All right, and let's see, how do we advance this? There we go. So starting out, what is hyperbaric oxygen therapy? And as I just mentioned, it's been essentially an unanswered question for about 347 years, at least up till about 2008. But the physiologic definition is that it's a dual component drug that uses increased pressure and increased oxygen to treat diseases. And it was the FDA who pointed this out in 2011, when for the first time, hyperbaric oxygen was put under the drug section of the FDA, medical gas section. Prior to that, it'd been under the devices section and always thought as well it's a treatment delivered in a chamber. But they posed a question to me, and it led to this understanding, which I hope is going to inform everybody here that we're in a whole new era now. The functional definition is that we are using a treatment that exploits all living organisms' sensitivity to pressure and oxygen. And of course, we all understand that living organisms are sensitive to oxygen. Without it, none of us would be alive. No living organism would exist. But how about pressure? What is pressure? We live with it. We don't think about it. But atmospheric pressure is the weight of air from the elevation of whatever you're at, standing wherever on the Earth, to the boundary of the Earth's atmosphere, which is about 62 miles up or around 100 kilometers. And that atmospheric pressure is the weight of that air in that distance. Hydrostatic pressure on the other, at the other end of the spectrum then is that weight of seawater at whatever depth you're at below the surface of the ocean. And so just to put this all in one graph, on the left-hand side here is pounds per square inch going all the way from 0, which would be outer space and 60,000 feet altitude essentially. And on the right side is altitude, the equivalent altitude elevation. So at 0 atmospheres pressure there at the bottom on the left-hand side here, right there, are, we are way up in the 60,000 feet and above altitude. And of course, here is sea level roughly at 14.7 pounds per square inch. And unfortunately, this the video thing is over my graph, but sea level is right here. And then below sea level, we're going up in pressure. Whoops, excuse me. We're going up in pressure. And here's the PSI. So sea level, we're here, altitude, lower pressures, below sea level, much higher. Well, here's the safe zone that humans exist in, with oxygen, of course, as we get up to altitude. But if we look at this, on Earth, birds, in fact, different species are found at different altitudes. And the same thing with plants and animals. They thrive at particular altitudes. If we go below sea level, the flora and fauna also are distributed by pressure. Now, there's actually an oxygen level as well, but they are very sensitive to that pressure depth, and that's where they live and thrive. And here, of course, are the fish and the different species that are found as we go down. So if we go back to the altitude and look at, atmospheric pressure, it's essentially the weight from the surface of air all the way up to about, 100 kilometers. And when you're underwater, it's that weight to wherever you are below the surface. Well, as it turns out, every chemical reaction in every living organism is affected by pressure. And pressure is a thermodynamic intensity parameter. This is the most math you're going to get and talk about this, but I want to make a key point with this little equation here. It's the free energy of any chemical reaction, and right smack dab in the middle of it is pressure, which means that essentially every chemical reaction in our body is affected by the pressure that we are at. Now, it can be just a small effect, but it can also be a very large effect. So when we take this to a hyperbaric chamber, the second that chamber door is closed, we are affecting our physiology, our chemical reactions, and what has now been shown and not been understood, literally the 360 years of this, the existence of this therapy, is that we are affecting over 8,101 of our 19,000 protein coding genes in our 46 chromosomes. And this is an effect that's unique in all of medicine. But to get that effect, you have to expose the entire body to increased pressure. And the only way to do that is put yourself in an enclosed chamber, i.e. a hyperbaric chamber. And this is an example of just a hard shell chamber with a patient in there. So what happens when you increase barometric pressure? Well, in 2011, when I had applied to the FDA to get an investigational new drug exemption to do the TBI study that we published in March of 2020, right at the pandemic outbreak, they sent me back a response. I was asking for a special protocol permission that if we got positive data with this protocol, could we use it for a new FDA indication for hyperbaric oxygen? And they rolled back and they said, look, wait a minute, you're just asking for one dose, and we view your therapy as a combination of increased pressure and increased oxygen. And we don't know whether either, both, or neither of them have a biological effect. You've got to prove that. And I'd been in this field 26 years up to that point. I thought they were crazy because no one at a clinical meeting, at any hyperbaric discussion, in writing textbooks, nowhere had anybody said anything about the bioactivity of pressure. So when the going gets tough, the tough go to the library. And I went to the library, and what did I find? This article in 1998, summarizing roughly 50 years of basic science research showing that even small amounts of pressure, look at the pressure up here, 1.0015, that's about a centimeter, to 1.3 atmospheres. What is that? The pressure limit of portable chambers in the United States. And within this range, they were documenting all sorts of biological effects. And so I kind of distilled that down. And this is in an article that you can look up, the reference on the bottom there, but 1.21 to 1.26 atmospheres. Look at this, 1.0015 to 1.015 to animal, human cells for 15 minutes or longer, causing all of these effects, elaboration of proteins, hormones, cell proliferation. And the activity started after just 1 minute of exposure. So, we're in a whole new world here, appreciating what this therapy actually is doing. And if we look, let me switch my video bar here for a second. If we look at the physiologic effects of pressure, I'm going to translate this to a very known commodity here, the ventilator. So the hospital ventilator that we are using in an ICU, what they did in this experiment was take alveolar macrophages from bronchoscopy. They washed the lung, got the macrophages, plated them, and they constructed this cell strain apparatus that delivered the identical pressure that a ventilator breath delivered, 0.07 atmospheres. They measured various things with the cells, and what they found was it activated NF-kappa beta, which is a main activator of pro-inflammatory cytokines. So think of what happens with COVID patients. Once you get on a ventilator, it's almost a death sentence. The mortality is extremely high. And what this is showing us is some of the mechanism of how this injury occurs. Also activates interleukin-8, TNF-alpha, IL-6, all of these things. And the ventilator plus lipopolysaccharide, which is an inflammatory mediator, had a synergistic effect. The whole point was mechanical ventilation induces inflammation and may be particularly deleterious in pre-injured or infected lungs. And that's what the LPS was showing. And of course, it may explain what happens to COVID patients when they go on a ventilator. So let me advance here. We're essentially, the physiologic definition was that treatment that uses increased pressure, increased oxygen, and we're using them as drugs to treat diseases. Well, it kind of begs the question, what kind of diseases? It turns out they're wounding conditions. And hyperbaric oxygen is essentially a treatment for wounds in any location and any duration. I'm sorry, I'm having a little trouble here. And how do we treat wounds with hyperbaric oxygen? What we're doing is we're repairing tissue and growing new tissue. And so the daily input here of a hyperbaric exposure, the output is reversal of the pathophysiology and repair and growth of tissue. And how do you do that? You've got to be able to stimulate cells to multiply and divide. So what's the definition, or I should say the mechanism of action? It's gene signaling, as it turns out. And this was shown in a series of experiments going back to 1997. But if we look at our DNA, and on the left-hand side here is just a picture of the double-stranded DNA, and it's in a supercoil. In the center are histone and other proteins with their reactive moieties, which are these color proteins that sit on the outside. These colored proteins, as it turns out, are where the epigenetic effects occur. So lifestyle, drugs, stress, all of the things we know that can affect gene expression are usually affecting these outside moieties. And when there's an interaction with it, let's say a chemical or a pesticide or something, it changes the conformation of the protein, the electrical charge, and it opens up the gene. And so here's just another schematic of it, our double helix and these proteins that are strung along and then in the supercoil. Well, so what is happening is, it turns out hyperbaric oxygen is acting at these epigenetic foci. The pressure and oxygen somehow is opening or closing the initial part of the genes and allowing them to be read. And this finally came to light in 2009. And here was the experiment. What they did was take skin biopsies from patients, and they separated out normal blood vessels and the tiniest blood vessels that are lined by what are called endothelial cells. These are the most reactive cells in our body. They put them in a petri dish and put them in a hyperbaric chamber and gave them one hyperbaric treatment. You can see the pressure right there, 2.4 atmospheres, 60 minutes. And they did a continuous gene array analysis. At the end of 24 hours, 8,101 of our 19,000 protein coding genes were turned off. The effect again was on the epigenetic part, those proteins controlling the genes. The largest clusters of genes turned on, and this is the key to our talk today, were the anti-inflammatory genes and the growth and repair hormone genes, i.e. repairing wounds, healing wounds. And the largest clusters of the temporarily suppressed genes were the pro-inflammatory genes and the ones that control cell death. So every hyperbaric treatment, we are stimulating growth and repair hormones and wound repair, inhibiting inflammation, and turning off cell death in areas of wounding in the body. If they gave a second hyperbaric treatment at 24 hours, the cells began to round up and form microtubules like blood vessels. This is in a petri dish. So the effect of pressure and oxygen on cells in our DNA is just profound. So what is the mechanism? We are modulating gene expression and suppression. It's an epigenetic gene therapy. And now let's go and look at how hyperbaric oxygen is used. In the US, we have this very narrow, limited number of diagnoses. And there's the list. You can read them. Air or gas embolism, which is air in an artery, carbon monoxide poisoning, crush injuries, decompression sickness, which is diver's disease. Everybody's heard of that. Problem wounds like diabetic foot wounds, exceptional blood loss, massive blood loss like getting shot and bleeding out before you die. You deliver hyperbaric to them, you can keep them alive. Radiation tissue damage. All of these, if you look at them, are wounding conditions. And the rest of them, skin grafts and flaps that are not healing, thermal burns, central retinal artery occlusion, which is a stroke of the eye, sudden blindness. Number 11 is sudden hearing loss. And then the last 5 or the last 4 are infections that cause wounds. So gas gangrene, the flesh-eating bacteria, etc. All of them, however, are wound conditions. Well, what happens if you go to Russia? They've got 70 diseases they treat. China, 49, Japan, 33, and 15 in the US. So, what is this therapy? A treatment for every disease? There was a critical article written in 1987 by Dr. Gavin Robin from Stanford. They identified 130 diseases hyperbaric have been applied to over 350 years. It turns out when you look at all of them, the vast majority are wounding and inflammatory conditions. My experience, I've treated about 90 to 100 different conditions, most of which are neurological. And how can you do that? How can you treat so many different diseases with one therapy? And the reason is we're not treating the disease, we're treating the underlying disease processes, the pathophysiology that cause those diseases. And it turns out those processes are common to many, many diseases. And they're sensitive to hyperbaric oxygen at varying pressures and oxygen levels. So if we look at the common wound pathophysiology, it is ischemia, which is no blood flow or low blood flow, hypoxia, which is low oxygen, and inflammation, which is dominant in almost all of them. Well, what kind of evidence do we have for the treatment of inflammation? And this is where this whole talk is going. This, I put in here, there are 7 of them, but here are 5, 6. There are 7 review articles on hyperbaric oxygen therapy effects on inflammation. They are widespread. In this one here, which was looking at it in inflammatory bowel disease, they cited a whole bunch of animal and human literature that inhibited inflammation. And they listed some of the cytokines and interleukins and so on. This one is effective hyperbaric oxygen inflammatory response in wound and trauma. Again, same type of thing, showing broad effects on inflammation and suppression of inflammation. Well, we also have evidence one of the most inflammatory conditions, which is the adult respiratory distress syndrome. And the reason I put this in, you will see in a minute. But when you are severely injured, such as trauma or overwhelming infection, the lungs can go into a state of almost shock, if you will, but it's called the adult respiratory distress syndrome. And here's an article on burned patients, controlled study. One group got hyperbaric oxygen treatment, one did not. And they separated out and took a look at those on a ventilator with ARDS. They had 20 with hyperbaric oxygen, 10 who were on the vent with ARDS, and they had 8 controls, didn't get hyperbaric oxygen, 5 on the vent with ARDS. They delivered hyperbaric oxygen. They had no deleterious effect. And what did they find? In this intense inflammatory condition of the lungs, they had a more rapid weaning from the mechanical ventilator in the hyperbaric group, 5.3 days versus 26. Now think of ICU expense and on a ventilator, what a huge change this was. They also, a lower mortality, 23% in ARDS patients. Well, I should say it was a lower mortality in that group, but in a separate study, which is number 2 there, which was a case series of all hyperbaric patients on mechanical ventilation treated at this one site, their mortality on the low end of the historical mortality for all patients for ARDS. So the point is the hyperbaric oxygen is inhibiting inflammation in lungs, and we see this in ARDS. We have evidence for it, and this is going to directly address what I'm going to talk about here with COVID. There's also another study that was done on ARDS, and this is in people who had severe chest trauma. 45 of them, 26 of them developed ARDS within 3 days of the trauma. And they had very low oxygen levels. That's a ratio there. But 8 of the 26 received hyperbaric oxygen, and the other 18 got standard supportive care. Hyperbaric treatment, if you look at it, these numbers, kind of put this in your mind for a minute, 1.6 to 2 atmospheres for just 4 to 15 treatments and only 40 to 60 minutes. Look at the mortality. None of the hyperbaric patients died. 77% of the control patients died. So evidence that this is effectively treating ARDS. Well, how about the application to acute COVID infection? Let's look at the coronavirus for just a second. That's an RNA virus. It's primarily in humans. It's similar to the previous SARS and MERS viruses, but it is also clinically very, very similar to Spanish flu, the last world pandemic. And we know that it's highly infectious, but comorbidities seem to be the most important issue in who survives and who has and who gets the sickest from it. And if you look at them, it's hypertension, diabetes, obesity, hyperlipidemia, chronic kidney disease, and of course, chronic lung disease, obviously, and infection of the lungs. If you have bad lungs, it's going to affect you, and the elderly. But if you look at those first 5, almost all of them are obesity related. And what this turns out to be really, COVID is a referendum on obesity. And, you know, essentially why our country was affected so much. That has, there are now studies out showing immunosuppression in obesity, and it's largely responsible for hypertension, diabetes, chronic kidney disease, and so on. So the risk factor is very important. Well, if we look at the natural history of the infection, it's an incubation for about 5 or 6 days, an infectious period for about 48 hours. And then, you know, the virus can be present as long as about 30 days, but people then either turn the corner and start, you know, getting better, or they go downhill. About 40% have mild disease, 40% moderate, and 3 to 5% end up with ARDS. Pathology is inflammation and exudate in the lungs, systemic inflammation. I'm sorry, this thing has got a mind of its own. And of course, the infectious process is only part of it. It's our immune response that seems to be the determinant of how sick people get and whether they die. But we also have systemic inflammation, thrombogenesis. The pneumonitis is the primary clinical problem with progressive hypoxemia, cumulative oxygen debt. And the conclusion is it's infection, inflammation, and hypoxia are the main drivers of the infection, morbidity, and mortality. Well, so let's just look at the lungs for a second. There's a photomicrograph right there on the top that shows us normal lungs, which is this filamentous, fine type of honeycomb structure. The air sacs here, and then the blood vessels, which run over the outside of the air sac. Here's what a COVID lung looks like. And you can see this is the alveolus. It's filled with this intense inflammatory exudate, which on chest X-ray gives you this picture with all of the diffuse infiltrates, which essentially clog the airspace and prevent the diffusion of oxygen into the bloodstream. Well, what's the effect of hyperbaric oxygen for COVID-19 infection? And history bears remembering. On March 10th, 2020, after 2 months of my wife, who's a nurse and hyperbaric nurse, kept questioning me about could hyperbaric oxygen have an effect on COVID-19? And I told her, of course it could. I mean, everybody has forgotten, but what is it, almost exactly 100 years ago, the Spanish flu pandemic, which is a corona type virus, swept over the world and was responsible for estimated, 50 million deaths. And what happened was, and this is another little secret, everybody tends to forget everything that's 25 years or more older, but hyperbaric oxygen's been around since 1662, but it's gone through a number of boom bust cycles that we don't have time to go through now. But there was a dormant period, and it finally got introduced in the United States in 1918. And there was an anesthesiologist, Dr. Orville Cunningham, in Kansas City, who happened to be vacationing in Colorado at Royal Gorge. And he was up in the mountains in the Rockies, and he got to thinking about how the mortality for Spanish flu was so much higher in the Rockies. And he surmised that it had to be due to the low pressure and the low oxygen. And he thought, well, what would happen if we increase the pressure and increase the oxygen? And eureka, he raced back to Kansas City, and they cobbled together from old parts and a boiler and made a hyperbaric chamber. The day they were to be operational and start doing the animal experiments, he was brought a dying Spanish flu patient and was asked to put him in the chamber. And this article describes it. Well, this is the book, The Uncertain Miracle, which describes it. His lips were blue-black, and he was deeply unconscious. Cunningham let the pressure build up and held it there. Of a sudden, the patient stirred. The lad's eyes were open. He was turning pink. He was in his coma. Cunningham continued that treatment for a little over an hour. Then intermittently during the next 3 days, he gave the patient additional dyes. The pneumonia victim starting to recover. A few days later, another moribund patient, pneumonia patient, and Cunningham saved a life. Well, what happened? He soon had a steady stream of patients. And this was then described in a journal article. Crude wooden shelf-like, this is so sensitive, were installed hurriedly in the latter compartment, which was his chamber, and he began his work. Only moribund patients were brought to the tank. Miracles were worked before our eyes, patients whose lips bore the blue-black livid stamp of the kiss of death and who were deeply unconscious, but if not too far beyond the brink, in a matter of minutes were brought back to a normal color and a normal to consciousness. Very shortly, a larger tank was supplied and numbers of such patients were restored in health. Well, what happened was a steady stream of patients, so much so that he built a huge chamber, and it was well documented. But the key to this was, what did he use? He was just using compressed air, and the pressures he was using, take a look at that, 1.34 to 2.36 atmospheres. So 1.3 is the pressure in a portable chamber, 2.3 is what we get the standard treatment generally in a hard shell chamber. And next thing you know, he started applying it to all sorts of acute and chronic illnesses, arthritis, et cetera. And he also noticed that there was a regeneration or ability to regenerate nerve fiber. Well, that huge that he eventually built, 108 feet long, that was driven by patient demand and the success saving all of these dying Spanish flu patients with just compressed air. Eventually, he moved to Cleveland, and one of the patients he had saved built him this 6-story steel ball hyperbaric hospital. which had an unfortunate demise as World War II rolled around and the AMA after him, treating things they didn't believe in. But the point was, his dose was 1.68 atmospheres of compressed air, which is only about 0.35 atmospheres of oxygen. We are breathing 0.21 atmospheres of oxygen at sea level. It's a little over 1.5 times that amount. And it was for 1 hour, 5 daily treatments. And he was able to salvage these. Well, if we look at the mortality in Spanish flu, it was due to two things: flu deaths, meaning the virus infection of the lungs, and secondary bacterial pneumonias, which accounted for the roughly other 1/3 of the deaths. And the interesting thing about this was that ARDS and bacterial pneumonia in Spanish flu and ARDS in COVID were the cause of mortality. But if we look at ARDS and Spanish flu, it had 100% mortality. In COVID, we're about 53%, probably due to modern medicine techniques and so on. But since antibiotics weren't discovered until 1928, roughly 10 years after the start of the Spanish flu pandemic, there were no antibiotic, and there's no antibiotic effect of hyperbaric oxygen. All the patients who had bacterial pneumonia and ARDS essentially died. And the ones were the ones who had ARDS due to Spanish flu and the viral infection and its inflammatory reaction. And the important point of that is that that's essentially what we can treat with acute COVID infection. So on March 10th, I put a little announcement on the website that history bears remembering, that maybe we should be applying hyperbaric oxygen to these moribund COVID-19 patients who are dying on ventilators. And within literally a day after posting that, my wife found an article that had been prematurely released to the public in China. And it had documented the treatment of, it was 2 articles, 6 patients. And I called a contact I had in China and ended up, through a translator, interviewing the treating doctor, Dr. Zhaoling Zhang in Wuhan, who had treated these patients. And at the time, she said we had 35 patients they had treated, no further infectious cases, and had stopped treating because they were at the end of the pandemic in China at that point, right as it was really breaking out here, or at least had been contained in Wuhan. But during the communication, what she told me was, I tried to tell her that this was done in Spanish flu 100 years before, and that it was just done with pressurized air. And there was this frenzied conversation with the translator, between her and the translator. I finally asked the translator, what is she so excited about? And she said that she believed that even though they were using oxygen, it was the pressure that seemed to have the effect. Because when they put the patients in the chamber, there were no inside attendants, no doctors. They went in the chamber by themselves. And if the mask came off, they were delivering oxygen. There was no way to put it back on. And they found that the patients without the oxygen mask on did not deteriorate, did well, which implied that the pressure was likely a more important effect on them. Well, the long story short was I wrote a little commentary in English in a journal to try to bring awareness to this, and was trying to work with the Chinese to get their study published. They finally published it in a couple Chinese journals. And I want to show you these patients and the experience. Their first one was the ventilator patient, and it's titled "The First Case of HBOT in Critically Ill Endotracheal Intubation Patient with COVID-19." They only gave them, that patient, 4 hyperbaric treatments at, look at that pressure. It's almost identical to what Cunningham used, but they used pure oxygen in a longer period of time. It was 1 hour and 40 minutes, but they were able to get the patient off the ventilator and salvage them. The next 4 patients, the second one, they treated at 2 atmospheres, which was a little higher pressure with oxygen. And then the remaining 4 were all at 1.6 atmospheres with oxygen. And here was their data that they shared with me. These are pulse oximetry measurements. So, we are breathing room air. Our hemoglobin's about 97% saturated with oxygen. And that's what we measure when we put that little thing on our finger and take a pulse oximetry reading. So on the left-hand side here, that's the percentage of our hemoglobin saturated. And you can see, let's take this red guy here. His on supplemental oxygen, he's getting oxygen by mask. only got 74% of his hemoglobin saturated. But after a single hyperbaric treatment, it bounces up and stays there for the rest of the day. But if the oxygen was just oxygenating the hemoglobin, it should be a temporary effect. And when you take away the hyperbaric treatment, which they did at roughly 10 a.m., they treated them, you shouldn't have a sustained increase. But in fact, that's what happened. By the following morning, it dropped down a little bit, but another treatment bounced them up. They stayed up, dropped down the next morning. The next one stayed up, and eventually it was sustained. And that was the pattern for all of these patients. Well, if you take a look at this and we plot it, here was their graph. This was the average of 5 patients, their oxygen level right before the treatment that morning. Here it was right after the treatment, the next morning, right after a treatment, the next morning, and so on. And what you see is this progressive increase. And essentially, they got up to this level of 90% where they were no longer critically ill and in danger of having to go on a ventilator. Well, it turns out the Chinese delivered between 3 to 8 hyperbaric treatments, average of 5, using oxygen at 1.6 atmospheres. Cunningham was using, for the Spanish flu, 1.68 of pressurized air. Again, what's suggested is the pressure is maybe the more important part. Well, I'm going to sum it all up with the treatment for acute COVID-19. It turns out a number of studies have now been done. And the governor of Louisiana, when we presented it to him, I tried to convert my clinic to a COVID clinic, but we couldn't do it because we would have had to ambulance transport these acute ICU patients over to our clinic from the hospital. It would have killed them. We couldn't do it. So the governor said, look, well, I'll give you $1 million to do the study at the hospital. And the hospital blocked us and wouldn't let us do it. So what happened, a hospital just north of us in Opelousas, Louisiana, Dr. Carrie Thibodeau, at their wound healing center, did a little case series of patients. And there have been now a number of these done around the country. Gorenstein did one in New York. This is one in Russia, a number in China. And here are the different doses they use. So 1.6, 2 atmospheres, 1.6 to 1.5. Nobody wants to use just air. They were all using oxygen. Nobody wants to remember that Spanish flu was successfully treated with just pressure. Well, as it turns out, if you sum up all those studies, varying designs, varying quality, most of them are not controlled. Some were. There were varying doses of hyperbaric oxygen therapy. However, every single one of them had a positive result. And since we know there is no known antiviral COVID effect, hyperbaric oxygen had to be treating the inflammatory component of the acute COVID-19 infection. So we have we can treat acute COVID infection. And what is suggested by the data is you can prevent them from deteriorating and going on later. All right, what about long hauler syndrome? Well, what is the long hauler syndrome? It's essentially residual ongoing inflammation post-COVID infection. And the definition of it is a syndrome characterized by persistent symptoms and or delayed or long-term complications beyond 4 weeks from the onset of symptoms. And 4 weeks is key because if we look, that's when the virus is no longer present in the nasopharynx or down to a very low level. And in the respiratory tract, it kind of burns out by about 10 days or so. So, at this point, the vast majority of people have no ability to treat the infection. However, the infection causes inflammation in potentially every organ in the body. And that is the COVID long hauler syndrome. And if we look at it, the symptoms, 80% infected with COVID will develop one or more of these 55 long-term symptoms. And, fatigue, 58%, headache, or I should say the people with long hauler syndrome, fatigue is 58% of them, 44% complain of headaches, attention disorders, hair loss, dyspnea, memory loss. The actual numbers now that are thought to have residual inflammation and are symptomatic from it, from COVID, is in the range of 35%. Most of it's musculoskeletal, but about 16 to 18%, as I recall, is neurological. And the pathophysiology of it, people have thought, well, maybe it's virus-specific pathophysiologic changes. So something that the virus did that's causing tissue pathology. Other thought is it's immunologic and inflammatory. That's probably the dominant component. Or the, quote, post-intensive care syndrome. Well, that doesn't really explain the ones who weren't in the ICU. So the people who get the infection and have the post-COVID syndrome who never made it to the hospital. You can't explain that with post-intensive care syndrome, being real sick in a hospital, hospital deprivation, microvascular injury, et cetera. So really what this is an immunologic syndrome. And this is a case, one of the first that I've treated. I've now treated 15 patients with long hauler syndrome. It was a 50-year-old lady, and she had had the COVID infection for about 10 days, headaches, chills, fever, myalgias, low back pain, sweats, and brain fog. And then after the infection, continuous fog, confusion, memory loss, headache, visual impairment, chest pain, irritability. And she had had viral testing that showed she was negative twice, but had positive antibodies, so we knew she had COVID. And anytime she had any physical activity or cognitive stimulation, it worsened her symptoms. Well, 27 days afterwards, she called me up, and I evaluated her and started treating her. And I treated her at an atmosphere and a half for 45 minutes with oxygen once a day for 13 days. And she reported she was about 90% back to normal. And her quote was, "I can't believe it." Well, it turns out, and I've got to move this down, did 2 more hyperbaric treatments, and then she had some very stressful incidents and had some symptomatic deterioration. She kind of bounced back from that, and then she went and got the COVID vaccine. Why on earth, I don't know. But she, because she had natural immunity at this point, but she got the COVID vaccine and had a marked deterioration later. All of her COVID symptoms returned. She then got on an airplane, flew out of town, so has a hypoxic stress. Cabin altitude on airplanes is 8,000 feet, 27% reduction in oxygen and pressure. Had a further deterioration and a immune manifestation. She had an oral herpes outbreak, saw a doctor, got put on Valtrex, Decadron, got some IV infusions, went to an ER, and 14 days after the last treatment I had given her, she went to a hyperbaric facility and tried to get some treatment. Her 50% oxygen at 1.4 atmospheres, which is about half the dose I had given her. And then another treatment the following day at another facility, but she didn't improve. Came back and I put her on a shorter treatment, but an atmosphere and a half, and treated her 6 times, and she made progressive improvement. Essentially, we treated long hauler syndrome here, and then vaccine exacerbation of it. And it's my suggestion, therefore, that, the vaccine reaction may respond similarly to the other 14 that I've treated, or now 15 total, who have had this long hauler syndrome. So we had, unfortunately, I wanted to publish this case, but we had no imaging. There was really, it's a completely symptomatic type of report. It's difficult to get that published. What subsequently happened now is in the Journal of Case Reports, there is a case report on long hauler syndrome, 55-year-old guy, 3 months post-COVID, decreased memory, problems multitasking, low energy, shortness of breath, physical fitness problems. And it turns out he is part of a study where they did perfusion MRI, diffusion tensor imaging, full battery of cognitive tests, and cardiopulmonary tests to look at physical fitness. And they gave them 60 hyperbaric treatments at 2 atmospheres for 90 minutes with the kind of US Navy schedule, 20 minutes on, 5 minutes off. And this has become the standard size fits all at this facility in Israel, where a lot of different conditions, but it's usually 60 treatments. And this is a picture of the before and after perfusion MRI. And it's a little hard to appreciate. It doesn't reproduce so well, but pre on the top, post on the bottom, and you almost have to blur your eyes and look at color. So the color scale here for perfusion, blue is at the low end, and increasing perfusion, you get up towards red. If you look carefully on these lower slices, you will see a greater amount of the higher perfusion colors. It's not a real dominant effect, but it is noticeable, it is measurable. And here were their cognitive tests. If you look at the pre-post and the percent change, this is taken right from the article, you can see the changes are small in percentage-wise in terms of cognitive change. This one here on verbal memory had a sizable one, but mostly they're in the 2 to maybe 8–10% range. But it translated to an improvement in symptoms. Okay, so hyperbaric oxygen can treat very likely acute COVID infection. We have increasing evidence. I know other people now who have done this, treating long hauler syndrome. And of course, what we're treating in these is the underlying inflammatory component. How about the vaccines? Well, if we look at the safety and efficacy of the BioNTech vaccine, COVID vaccine, for the first 6 months, and this is the trial reported in the New England Journal of Medicine by the funded investigators, the drug company funded investigators. Here was their statement. Analyses of adverse events during the blinded period included 43,000 participants, 16 years of age or older. Reactogenicity events among the participants who were not in the reactogenicity subgroup were reported as adverse events. I don't understand that statement really, which resulted in imbalances between the BNT162b2 group and the placebo group with respect to adverse events, 30% versus 14%. Related adverse events, 24 versus 6, and severe adverse events, 1.2 versus 0.7. New event. Okay, so it seems to me that there are more than the placebo group, but I mean, it's kind of mumbo jumbo the way it's explained. If you then go and look at these adverse events, they're not in the article. It's in the supplemental material. And, they've got them graded by severity, and they've got the fever, side effect, and so on. You can see that most of them are mild to moderate, and greater for the vaccine compared to the placebo in most of these, but not a whole lot. And here again, so fatigue, more common. There's a bigger discrepancy there. Headache, muscle pain. But this is their actual data. But what's also been published is this study by Dr. Rose in Science, Public Health Policy, and the Law, which is associated with IPAC. And this is the actual US vaccine adverse events reporting system data for COVID-19. And what she shows is this accelerating rate as, of course, more and more vaccine was delivered. And then looking at neurological, immunologic, hospitalizations, those presenting to the ER, death, and the cardiovascular events. And you can see these immunological ones kind of dominate, the numbers here, but, steadily increasing numbers. And these are adverse events per million fully vaccinated. So, 250 immunologic events. And here's the age group distribution. So it seems like most of the adverse events are in the, middle age, well, starting 30, really younger, to up to the 70-year-old age group, but kind of in the middle age groups of the population. Well, So what about HBOT for vaccine injury? What's the pathology? It's immunologic. I mean, this is not a live virus where we could claim a viral destructive event. This is an immunologic process. And while we have no data yet, really no experience, my one case here that I can draw on, do we have evidence, let's say, for hyperbaric oxygen effects on other vaccine injury? And, this, of course, opens a whole can of worms and a very controversial issue, but there are a lot of people who believe that despite the studies that are done, and part of the explanation around that is the how do I describe it? Insufficiency of the vaccine events recording system, adverse events recording that, the autism events were not recorded. The point is, some people believe that autism is related to possibly the aluminum or possibly just the immune stimulation that is in various vaccines, childhood vaccines. Well, if we look at autism, though, a dominant component of it is inflammation, both GI, but even central nervous system. And what we know is that, and let me just back up before moving on from there, there are multiple studies now published on hyperbaric oxygen in autism. And they are controversial because some are positive, some are negative. However, there's also some data showing that it is suppressing the inflammatory immune system process in autism, at least hyperbaric oxygen having an effect on the immune system. And if you go back to one of those review articles I wrote, it's by one of the doctors who authored one of the autism articles, Dr. Rosenthal. The point is, though, autism, if you look at the treatment of hyperbaric oxygen, there's a substantial experience with this. And what it suggests is that there's a beneficial effect and that we are treating inflammation. So, by analogy, I would tell you, and based on everything else that I'm showing here with treatment of long hauler, treatment of acute COVID, we have the possibility of treating vaccine injury with hyperbaric oxygen and having a response. And I know Dennis had mentioned and wanted me to just have a word about dysautonomia, because I know that's part of, or can be a component of, this immune injury that people are seeing. As it turns out, multiple studies on population normals and divers showing that hyperbaric oxygen affects heart rate variability, which is an autonomic function. And they are positive, meaning going under pressure has an effect, and it's indirect, but the effect is on the parasympathetic nervous system, increasing the parasympathetic and decreasing the sympathetic output. It's kind of like the diving reflex, if you will. But it has a beneficial effect. And in fact, I've treated now a series of patients with dysautonomia, and this was the only thing that seemed to give them benefit. Lastly, I just want to focus on how do you dose hyperbaric. So it's a two-component drug, as I mentioned. And every human being is idiosyncratic. And when you add a disease process on an idiosyncratic person, you get idiosyncratic squared. You are your own person with your own disease. And it's why therapies that take a one-size-fits-all approach don't work. And this has been the problem in hyperbaric medicine. Because of the lack of understanding of it, people have looked at historical protocols. Someone used this dose, it worked, okay, I try it. All right, well, geez, it worked for a series of patients. That's the, quote, protocol. But in fact, if you walk into any physician's office, anywhere to get treated for anything medically, it is not protocol driven unless you're on an experimental protocol where everybody gets the same dose or the same treatment. And so, hyperbaric oxygen, in fact, is no different. And especially when we've got a component drug. And the pathophysiology we're treating in a given patient, time in their disease process, can be sensitive to different pressures and levels of oxygen. Well, we tried to look at this for a or excuse me, I should say we did look at this for a full decade in the 1990s. And what we did was do brain blood flow scan on a neurological patient, and the following day put them at a given dose and repeated the scan 3 hours later. If we could see a pattern change to a more normal pattern on that second scan, it didn't matter what the pathology was. It said that your brain responded positively to that pressure and oxygen. It turned out it predict with 100% accuracy people who would go on to experience neurological, cognitive, or symptomatic improvement with repetitive hyperbaric treatment at that dose. Well, that's fine, and it works well, but it allows me to look at one dose. If I want to look at another dose, what do I have to do? I have to go and do another hyperbaric treatment and another SPECT scan, another dose, another SPECT scan. It gets very expensive, and insurance companies don't like to reimburse for it anymore. So we have a little bit of a problem. The other thing, though, was that second SPECT scan was the delayed effect happened in the chamber. We could never see what the brain was doing in the chamber. Now we can. And now what I'm doing is I'm using quantitative EEG, and I want to just show you. So a given neurological patient, here's what we used to do with SPECT, and this is an example of a little autistic kid, 5 years old, and before and after single hyperbaric treatment. And as it turns out, so we're looking at the patient, this is a brain blood flow scan and a three-dimensional reconstruction. And we're looking at a face on, forehead is here. So these are the lobes, the eye would be right here. And here are the temporal lobes. If you look at SPECT studies, 90% of them show abnormalities in the temporal lobes. It's an injury to the temporal lobes primarily that gives us autism. If you take a look at these, they should normally look like a kind of hot dog bun end on, very rounded structure. And you can see it's just a fragment outline. Here was after one hyperbaric treatment, and you can see the improvement in blood flow to the temporal lobe. Still not normal, but a noticeable change. Well, here's the quantitative EEG, and what I have is a wireless headset that's Bluetooth, and it penetrates the chamber. And what I can do now is put someone in a chamber and take them through a dosing profile and look at a variety of different doses, as many as 5 of them, in a single hyperbaric treatment. And across the top here, looking down each of these, here's right ear, left ear, nose, back of head. We're looking down on the top of the patient's head, and what the computer does is flatten it out, the brain, into a circle. So frontal lobes would be up here, temporal lobe on the side, temporal lobe, top of the head here in the center, and the back would be cerebellum and occipital lobes. And these are color-coded, the different frequencies. So we have 40 different frequencies of electrical current in our brain. And they're usually divided into delta, the lowest frequency, where usually you see injury manifest, theta, alpha, everybody's heard of alpha state, your awake state, and then the higher cognitive frequencies, and these are split here, low beta, beta, high beta, and gamma. So it's delta, theta, alpha, beta, gamma. And these are then the connectivity maps, looking at the over or under connection for all the different points in the brain. Down below here are the standard deviations compared to normal. So if we look at left hemisphere, which is going to be the left side here, and we're looking at delta frequency up here and all of the different lobes, this patient has way too much delta, consistent with their brain injury. 3 to 4 standard deviations from normal, too much. So 95% of the population is within plus or minus 2 standard deviation. But what happens is this is rendered live. So I can sit and watch this live, see this changing, record it, and we get quantitation on it. The other thing is that we can look at connectivity maps. And this is a 3-dimensional rotating phantom, but what happens is, I'm able to look at the different connections in the brain and how they change with different pressures and oxygen. This is surface map, looking at the surface and the different frequencies, also color-coded by standard deviations compared to normal. So what we're essentially evolving to is a way to look at a person's brain on hyperbaric conditions and different conditions of dose, pressure, and oxygen to try to maximize function, and then do that individually for a patient and their given disease. So if I could sum all of this up, hyperbaric oxygen is a dual component drug composed of increased pressure and increased oxygen. It has effects on disease pathophysiology and gene expression that are dependent on the dose of pressure and hyperoxia for a given patient with a given condition at the time of intervention in the disease process. It has primary effects on inflammation and immune dysregulation. And that is the most important point I want to make today for your condition, this vaccine-related immunologic pathology that you have. And it likely explains its benefit in not only acute COVID infection, but long haulers syndrome, where we are now seeing in benefit in case experience, and there's soon going to be a published randomized trial on this as well. I only have one case where this seems to have benefited someone with adverse reaction to a COVID vaccine, but it likely works the same way. And I wanted to give you hope that this likely could help your condition. And that's it. Thank you for your attention.
Thank you, Dr. Harch. That was a great talk. And do you have time for questions? There are quite a few.
You bet. I know we ran to the limit of the hour here, but I'm not limited by that if you're not. So,
well, anyone who has time can stay on, and
sure,
others can leave. So let's see. Let me see. So, there are a lot of questions about hard shell versus soft shell. I guess with the hard shell, it has to be prescribed by a physician. Soft shells more readily available without a prescription. Could you give us a little thing on it? Yeah.
Technically, that's not correct. Every hyperbaric chamber is a prescription medical device. And it's just that the FDA hasn't enforced it. But for you, for instance, to purchase a portable chamber, you have to have a prescription from a doctor. At least you're supposed to. It's like a pill bottle. So that chamber, it's a prescription and a dose that's written for you. But it turns out the portable chambers, because there's such a low incidence of injury with them, or at least, let me say this, there isn't as much reporting of any injury that can happen or adverse events. They're being put in all sorts of facilities run by business people, usually not kind of as a medical practice. So the barrier to getting in a portable chamber is pretty low. The hard shell chambers, though, what happens is usually to get one of those, the chamber manufacturers will only sell them to physicians. And because of the capital outlay, so if you look at the brand new now hard shell chambers, the minimum ones are in the $80,000, I think, is a Peruvian chamber, but most of them are up in the $120,000 range. So they're usually bought and put in medical practices, which partly explains the difference in cost as well. Portable chambers are anywhere from, oh my gosh, $4,000 or $5,000, some of the very cheapest ones up to $25,000 to $30,000. So the prescription issue, while technically there's supposed to be one even for the portable chamber, a lot of people can get treated in them without it. It is still a medical treatment, though, and considered. The difference between the chambers, though, is the material and the construction. So the portable chambers are FDA limited to 1.3 atmospheres. And if you look at all that stuff I presented, so even though there is bioactivity in that lower range, at least the experience for COVID, acute COVID, and even long haulers has been at higher pressures than the portable chambers. Now, would it work in the portable chamber at that dose? Yeah, it can. It might. And I've even got some patients that have responded at that lower pressure because when I QEEG'd them, the higher dose didn't look good for their brain. So there's a difference in construction material, those chambers are only supposed to go to 1.3 atmosphere. The hard shell chambers are rated to 3 atmospheres, which is the equivalent of 66 feet of seawater pressure. And so you can't, in a portable chamber, entire range of treatment for all different diseases that you see there, let's say with Russia, or that I put on some of those early slides. You need a hard shell chamber for that. The other big difference is the portable chambers are not rated and have not been tested for enriched oxygen environments. So if we look at fire risk, oxygen is not explosive. Oxygen is an accelerant. And the higher the percentage of oxygen, the faster something will burn. And that acceleration begins at about 23.5%. So atmospheric pressure air, like what we're breathing, 21% O2, burn at a normal rate. By the time you get to 23.5%, that rate starts increasing. And the greater the percentage, all the way up to 100%, it burns very, very fast. And it's augmented by the pressure component as well. So the portable chambers have not been cleared for an oxygen-enriched environment. And you can't pressurize them on pure O2. The reality is, though, people hook up oxygen concentrators and they'll use oxygen concentrator by nasal cannula or mask in the chamber. And the most you can get them up to with a 10-liter oxygen concentrator is about 25% O2. So there's a little bit of risk there, but that's the main thing. You don't want to pressurize them with pure oxygen with the cylinders, because all it takes is a spark in that environment and you have a fatality. So any fire in a hyperbaric chamber, they are almost universally fatal. But in a portable chamber using compressed air, the fire risk is not there.
So if
the difference is chamber construction, cost, the pressure that it can go to, and the amount of oxygen that you can inflate the chamber with. And those are the big differences. But really what matters is what you respond to. So if you respond to a low pressure, yes, you can do it in a portable chamber. And for instance, look at all these drowned children that I treat, and you probably have seen the little girl whose article we published. It just went all over the world. They released press releases on it and so on. I treated her first at home with normal baric oxygen by nasal cannula, just 2 liters a minute. And she responded. And if you go to the article, we posted the video showing this dramatic change in her. And then I gave her pressurized air. And all of that was at a very low pressure. So the point is, it's what you respond to as a patient. You may need a higher pressure. You may need more oxygen. And that's what you have to find out.
So would you recommend in these centers with the soft chambers not to be given concentrated oxygen?
Well, it's, I can't make recommendations. The reality is that, like I said, the most that it gets up to, I have patients that we transition them to portable chambers after I have shown that they'll respond in that low dosage range. Because look at these drowned children. You cannot clean up that and repair that degree of profound injury with a 40 treatment course. It becomes a very long-term treatment. Well, I progress them to this, but we take the usual precautions in the chamber such that even with some increase in oxygen in the chamber, it's not a significant risk to them. And whether it's luck or not, I mean, it's been true generally, I think, in the field that it's been pretty safe. Again, you don't want to pressurize that chamber with pure oxygen. That's where you have a really significant risk. The other thing about the portable chambers in these places is, I don't know if you've cleaned one of them. They're very inconvenient to clean. You have to get in them, and they have an internal frame. And wiping them down, and the cushion, the sheets, the linens, etc. A lot of these places don't do that, and so if you're going to do that, insist on them changing the sheets and cleaning it for you. The hard shells are easy. You can take a mop And you literally, with the special cleaning agent, you just, go down the inside of the chamber and clean the acrylic, and they're very easy to do. But the portables are a little more different, a little more difficult.
Speaking of risks, are there other risks to hyperbaric therapy, oxygen therapy?
There are two other categories of risk. The most common thing is ear problems, so pop in your ears. And as it turns out, that's the most common thing, but just with technique, it can be mitigated. So, the portable chambers, just to give you an idea, they compress at a rate of about 110 liters a minute, is what the little portable compressor. The hard shell ones generally run 200 and 400 liters a minute. And so what happens is, at that lower flow rate, they compress slower than, the hard shell, you can adjust it to compress very, very slow or very fast. But the portable chambers go at a kind of fixed, slower rate. And you can even slow it down more if you want. But you can mitigate a lot of the ear effects by just going slow. So the most common problem you can mitigate. The other one is oxygen. And it gets into a problem more with children and long-term treatment with both adults and children, because everybody wants to think that more oxygen is better. And so what they want to do is give maximum oxygen by face mask. And depending on how long you're staying in the chamber, the number of chambers, eventually you can get side effects from it. And that's a figure. And this is from two chamber manufacturers, one in Australia, one in the US, who sell portable chambers. After 1 year, 1/3 of portable chambers sold end up on the market, either sold on eBay or someplace else, or given away. I estimate that at least another maybe quarter, maybe a third of them become a piece of furniture, because people, they go and they use it and they may not get a benefit because either they didn't use oxygen, or they did whatever, they didn't dose themselves and didn't get a benefit. And so but the risk of doing it is pretty low, of having a problem with them.
Good. That's good to know. Well, I'm just curious, when you go to a storefront that offers this, who determines the dose, the frequency? Is anyone?
It's like the guy at the 7-Eleven operating the microwave on your burrito. It's the business person who's operating the chamber.
Not a medical person.
Usually not. That's what I tell people, is, to whatever facility and scope them out. Find out who's running it and how they're going to treat you, who's overseeing it. The vast majority of these places, you're a physician, this is a medical subspecialty. It's a medical practice. It's the fact that there are a lot of political reasons why this has happened, but because it's been found that this lower pressure range can be beneficial to people, the barrier to entry has become very, very low. So at a lot of these facilities, there are no medical people there, and you kind of get what you choose, or they pull some quote protocol off that they want to use, or we've had good result with nasal cannula oxygen, so you get a nasal cannula, and the pressure limit of the chamber usually.
Okay. We have several injured who live in Louisiana and would be happy to be study subjects if you ever want to look at them. Just
okay.
Yeah.
We don't have any formal study. In fact, I can't call them study subjects, if you will, because once you do that, you have to prospectively go through an IRB. You can treat patients in retrospective, say, oh, hey, I'll report that case, But so I currently, we finished our last study, And a good, I'll tell you what you can do, and everybody who is on this. On March 17th, I published a systematic review on hyperbaric oxygen in mild traumatic brain injury, persistent post-concussion syndrome. And you can easily get it. It's a free download, peer-reviewed internet journal, Frontiers in Neurology. Just Google Harch Frontiers in Neurology. And I think the second thing that will come up is the systematic review. Punch it, and it's a free download. But what it does is analyze all of the studies that were done based on pressure and oxygen, and it'll give you this concept. And what the conclusion was that a narrow pressure range seemed to be more effective than the actual increased oxygen that was given. But it'll kind of give you an idea also about this whole thing. So when you go to a facility, you just need to interview the people and find out what they're doing and you know, what experience they've had treating your diagnosis.
Have you had any patients with small fiber neuropathy?
Yes, I've had a few.
Because a lot of us have that from our vaccine reaction.
Right.
What is your experience?
It's an inflammatory nerve injury. And I've only had two, I think, with that. And I had a positive result with them. You know, the problem is I don't have longer term follow-up, and I don't know. Hyperbaric oxygen does not kill the immune system. So we don't have the ability with pressure and oxygen to go and kill the source of the inflammatory reaction that's inflaming the nerves, etc. What you do is you end up suppressing it, and you suppress it, hopefully, while you minimize re-stimulation of whatever is stimulating that immune response. But usually with inflammatory conditions, it ends up being that you end up having to do the hyperbaric oxygen intermittently on a longer term basis.
Okay. Many of us in this group have GI issues as a result of our injury,
Yeah.
delayed motility, bloating, all kinds of motility issues, which probably are related to dysautonomia, in my opinion. But have you had any patients like that? And if so, what was the response?
I had patients with other GI problems. And again, going to the autistic kids, this helps their GI problems. If we look at also the drowned children, one of the components of their autonomic nervous system injury, a lot of them have acute storming. But one of the residual manifestations of it usually is GI, it's constipation.
Yeah.
And almost uniformly, we will see a positive response with that. There's even a published experience out of China on treatment of autonomic storming. I mean, your GI could be due to more of this small fiber neuropathy as well, or it could just be inflammatory in nature. I mean, the gut is a major part of our immune system. But this generically inhibits inflammation in the body at any site of inflammation.
Okay. Some people in our group have had adverse reactions where they've actually gotten worse with hyperbaric oxygen. Do you have any explanation for that?
It's dose related, very likely.
So if they were to get a lower dose, they might have done better.
Yeah, I'd be very interested to find out how much oxygen they were given. You know, was it a hard shell, a soft shell one? There are some people that are exquisitely sensitive to this. And sensitive meaning too sensitive and they can't tolerate it. I've usually seen this in children, but I've got some adults as well, to where if you go back to that article on micro pressure, I've got patients who we are treating in that very low range. And when you go higher, they have problems. So I would tell you it's one of two things. It's a dose issue, or it may just be that they are so sensitive to any pressure and hyperoxia that this is a treatment that just isn't going to impact them.
Right.
Just a little more elaboration on that. When we first showed this in 1992, I treated the first cerebral palsy child in North America with hyperbaric oxygen. And what happened, we had a whole series of them, studies got going and so on. And then I started getting phone calls from parents around the country. My child, we went and got hyperbaric oxygen and now he's worse. And what happened was I sat down and I took notes on this. And I eventually wrote a book chapter, and almost all of these, every one of them, were oxygen toxicity problems where they were overdosed. And it was a matter of giving a root dose. Nobody was watching them. It was no practice of medicine. And what happened is, as they developed side effects of it, they didn't recognize that this was oxygen toxicity or overdosing, and they just kept treating them. The other thing that happened was, if the mythology, if some was good, more had to be better, they started treating these children at higher pressures. And we started seeing these side effects.
Okay. Someone asks if there is any concern if you have a tracheostomy.
No. I mean, well, no, in terms of the tracheostomy is no risk going in a chamber, as long as it's not a inflatable bulb on that tracheostomy. So tracheostomy tubes, usually by the time we get to treat them, they're not in the hospital. When you treat them in the hospital and they've got an air cuff, yeah, there's a problem there. You have to exchange the air for saline so it doesn't compress in the chamber. But the typical outpatient who has a tracheostomy, there's no issue or risk there. The only problem is being able to deliver what you want. So if you want to give oxygen to them, you know, it's a little trickier in terms of getting a trach mask to deliver it, as opposed to a standard mask or nasal cannula or so on. So you have to make some accommodation there.
Some people are getting IV ozone treatments. Can you comment on that? And is there any correlation with hyperbaric oxygen treatments?
Well, it's an oxidative therapy, and I actually believe in ozone therapy. And, you know, there's literature that supports it, but I don't have any, well, I'll take it back. I do have some personal experience with it, but I don't have any, you know, with COVID. So I know that the oxidative therapies can have some anti-inflammatory effects. And really what matters is if you benefit from it, you know, what works, I would do.
Right. Let's do a couple more questions and let you go free. Another question is, my understanding is that pulse oximetry measures the total of multiple gases, including oxygen and carbon monoxide. I hope to disaggregate this to measure all of these gases individually. If carbon monoxide were to rise after HBOT, it would seem like a benefit on the oximeter.
Okay, well,
it's a tough one.
Yeah, there are now carbon monoxide pulse oximeters where you can actually measure carbon monoxide levels, you know, and binding to hemoglobin. But I don't understand the question. Carbon monoxide increasing with a hyperbaric treatment, how does that happen? I don't, maybe that person can.
Margie, can you elaborate on that question? Margie?
Oh, hi.
Hi.
Hi. I would defer to my friend, the toxicologist, who introduced this to me. I think I might be able to send some references.
Well, no, but what do you, I don't understand what you're asking. How does carbon monoxide get in the chamber?
Oh, it's not an external source. It's an endogenous production.
Oh.
That's the
Okay.
explanation that I have. Yeah, not an external source.
All right. Well, you know, that's a good question. I can't answer that. I have never seen anything about carbon monoxide levels rising significantly with hyperbaric oxygen. In fact, it's the exact opposite. You know, if you go back to that list of the 13 indications I showed you, or 15, carbon monoxide poisoning is one of them. It is considered by many, you know, a treatment of choice if you have the chamber available. And what's been shown is that the carbon monoxide level dramatically drops. The half-life goes from room air, which is, you know, in the multi-hour range, 6 hours, to under hyperbaric conditions, roughly 24 minutes or so. So it rids the body of carbon monoxide. You don't produce more of it. So you know, carbon monoxide is also a brain neurotransmitter. It is in our body, and we make what, less than 1% of it is our usual body level. But I don't know what your toxicologist was talking about. Because hyperbaric oxygen, any increase in hyperbaric in oxygen blood is competitive with binding of carbon monoxide to hemoglobin.
Another question is, should I take a break after 40 sessions? If continuing with more sessions would be helpful, how long should the break be?
Well, it depends on what you're treating and when you're treating it. So, you know, if you're in the chronic phase meaning the or more, generally that's where 40 treatments has been shown to be effective, or I should say you need that number to generate a positive outcome that has durability. But it is a number, that number actually came from the perfusion metabolism encephalopathy study that we did from 1994 to 1999. And it started with a question to my mentor with this, I talk about in my book, how I got into this field, and or I should say how we made a discovery with neurological application. I had this demented diver who was months out from his accident and in an extreme situation. And I called up this Dr. Neubauer and asked him, what would you do with him? And we discussed it. And I said, well, how many treatments does it take to get a permanent measurable improvement? And he said, why don't you try 40? As it turns out, 40 is kind of a reproducible number that has been shown for diabetic foot wounds, for chronic radiation injured tissue, and other chronic wounds treated with hyperbaric oxygen. And so that's what we started. And we then started looking at blocks of 40 treatment. But in fact, if you've got somebody still improving at 40 treatments, you don't have to arbitrarily stop there. We use that number to encapsulate everybody who could get a benefit and a sustained benefit if we got at least that number of treatments. So again, it gets to the practice of medicine issue. If you're still improving at 40, and depending on the dose you're on, you can keep going for a while. But if you go too long, people can even get habituated to it, where you have withdrawal effects if you stop. So I would tell them, if they've got a chronic problem, you know, go to 40. And if hopefully your doctor and you're with it, if you're still improving, you can go on a little bit farther. But yes, you should then take a break. And what we looked at was a minimum of about a month to allow any oxidative stress to wear off, also give people a break from the tedium of it. But it's turned out, and it's worked out very well over the years.
I'm going to ask one last question. We have a lot more, but time is running out. How can you prevent ear and sinus pain during the treatments?
Okay, yeah, how can you prevent it? Well, first of all, sinus problems, it's a rare person that will have it in the chamber, just who is not ill. So just your average person off the street. Now I'm going to tell you, on routine MRIs in Southeast Louisiana, over 50% of MRIs have sinus inflammation. So people have chronic sinus inflammation. It's because everything grows down here, you know, in abundance. And there's just a lot of pollen and irritation. But given that we don't get sinus pain in maybe, I don't know, 1 in 100 or 1 in 50 patients, And there's no way to predict it ahead of time, meaning you have to get in the chamber and you find out if your sinuses are sensitive or if they're plugged. If you do, then what has been shown to work, you've got to use decongestants. And simple Sudafed, there's only been one study done. It was Sudafed versus Afrin, essentially. And the Sudafed worked better. So depending on the cause of your sinus problem, if it is allergic, take an antihistamine. And you can put a decongestant with it. You could also use an inhaled steroid. But there's, first of all, to prevent it, you don't really need to prevent it because it is such a low risk thing. I mean, you don't want everybody routinely taking decongestants before they go in a hyperbaric chamber. It's unnecessary. You want to, if you have a problem and you identified it, then stop, go ahead and treat your sinuses, get it under control, and then go back in the chamber. And the only way then to try to accommodate it is a slow pressurization to where, you pop your ears and you do that just at a slow rate.
Would it be okay if I ask one more question?
Of course. Look, I've got time. I told you, I'm happy to.
Thank you. Have Gardasil reactions been treated successfully with HBOT?
Don't know. I haven't treated any, but I would apply the same principles that I filled this lecture with here. What's the nature of it? It's going to be an immune dysregulation. Hyperbaric oxygen has these broad effects on the immune system through gene expression. And so I would tell you there'd be a good chance you might be able to help it with hyperoxygen.
Well, I think we'll end this wonderful lecture, and thank you so much. This is a topic we're all interested in. Many people are getting hyperbaric oxygen therapy, a lot of success stories, and maybe
Yes.
at some point we can meet again.
It's a wonderful therapy.
Catch you up.
Has a lot of applications. Do me one favor, send me a recording since it wouldn't let me do it, okay?
Of
And
course.
what I will have this posted as well, so they can either get on my website or it'll be on a YouTube channel or whatever, but we'll make it available to everybody. Okay?
And again, remind me what your website is.
HBOT.com.
It's
Very
simple.
simple.
Yeah, and there's
Yeah.
a lot on there. All right. Well, thank you again.
All right. Have a good night.